Headphones on?
Hello everyone, welcome again. My name is Craig Spencer. I'm the audiology team lead for the Widex brand in Canada, and I'm joined again today by Danny Pineault. Welcome, Danny.
Thank you.
So Danny is an experienced audiologist with over 25 years of experience working in both private and non-profit organizations. He is a recognized authority in the management of very complex tinnitus cases. He is an adjunct professor at A.T. Still University's School of Health Sciences, and he is particularly interested in the areas of tinnitus, hyperacusis, evaluation and management, which we're going to talk a lot about today, as well as exploring connections between age-related hearing loss and cognitive decline. So welcome, Danny.
Well, thank you, Craig, for that amazing introduction again. I'm excited to be here for a second episode, and once again, really appreciative for the opportunity to continue this much-needed conversation on tinnitus and focusing on evidence-based assessment strategies with this population.
Yeah. Absolutely. Welcome again. We're happy to have you. Okay, why don't we just dive right into it? Maybe we can start by talking about some of the assessment strategies that you'd recommend for the management of the tinnitus population.
Great. So to answer that question, I'm going to be quickly revisiting the iceberg model as it applies to bothersome tinnitus, okay? Mm-hmm. So do you remember this illustration I introduced in episode 1? Yeah?
I do, yeah.
Okay. So bothersome tinnitus can be divided into two interconnected components, an auditory component and a non-auditory or mental health component, okay? So using an assessment protocols that enables clinicians not only to identify or detect hearing issues frequently associated with tinnitus, such as hearing loss, difficulty understanding speech in noisy environments, or reduced sound tolerance conditions such as loudness hyperacusis, but an assessment protocol that also enables or allow clinicians to uncover potential cognitive, behavioral, and emotional health factors that often contribute to and maintain or prolong the negative experience with tinnitus is needed to obtain a comprehensive perspective of the patient's symptoms. Okay?
Right.
So as we reviewed in episode 1, the tip or visible part of the iceberg represent the auditory component or the hearing issue associated with tinnitus. Now the submerged or invisible part of the iceberg represents the mental health, the non-auditory or component or the mental health aspect associated with bothersome tinnitus that are not immediately evident or readily accessible for patients. Okay, so these include cognitive health factors such as misconception or misinformation about tinnitus symptoms, along with negative thought patterns like catastrophizing tinnitus symptoms or fixating on tinnitus causes and treatments. It also includes behavioral health factors such as maladaptive coping strategies, or commonly referred to as safety-seeking behaviors that are used by patients to reduce the impact of tinnitus in their lives, such as constantly monitoring tinnitus symptoms or excessively using earplugs or noise-canceling headphones or avoiding social settings to minimize exposure to loud noise. Mm-hmm. And finally, your emotional or frequently undetected and untreated mental health conditions or disorders such as anxiety and depression. Now, left unaddressed, chronic health conditions can not only amplify the perception of tinnitus, but can also increase distress associated with the symptom and jeopardize the efficacy of hearing care intervention. So I know it's a long response, but so it's recommended that to extend the assessment beyond the traditional hearing test to capture this comprehensive clinical understanding. So it is advised to structure the assessment around the following 3 axes. Axis 1 being your hearing assessment, axis 2 being your tinnitus evaluation, and axis 3, the well-being screening.
Okay, so now I'm hoping you can walk us through each of the 3 axes of the assessment process and maybe some insights on clinical implications.
Yeah. So axis 1, or the hearing assessment, always starts with a structured interview, or at least the completion of a detailed case history form, okay? So clinician needs to collect as many data as possible to start building this comprehensive understanding of the patient's symptoms,
Sure.
okay? So it's important to investigate the circumstances or events surrounding the onset of tinnitus, if they're known to patient, of course, right? So was tinnitus triggered by noise exposure, head trauma, or changes in health or medications, right? So if medication is identified as a potential trigger, then clinicians need to refer their patient back to their primary care physicians for further evaluation.
Of course, yeah.
Now, a case that comes to mind that I saw recently reported or experienced very loud ringing in the ears after being prescribed gabapentin for chronic lower back pain, right? So gabapentin is an anticonvulsant that is often recommended for chronic pain. Now, you know, this patient's tinnitus ceased almost immediately after stopping the medication.
Okay.
So I'm aware that these cases don't happen that often, but they do occur from time to time. So it's important for clinicians to be vigilant and investigate potential ototoxicity of newly prescribed medications. I don't know if you knew, but in the United States, there were over 450 prescriptions and over-the-counter medications known to cause either tinnitus or temporary or permanent tinnitus and hearing loss.
450 is a lot. We could probably have a whole podcast episode on that topic, can't we?
Absolutely.
For sure. Okay, so let's talk a little bit more about the case history, because that's an important part of the process. What are some questions that clinicians should ask, or some additional questions that clinicians should ask?
So clinician would gain in investigating the following 6 aspects of tinnitus. First is symptom duration. Is tinnitus a recent symptom, meaning less than 6 months, or is it a chronic symptom, meaning more than 6 months, right? So this will help clinician determine the right time to initiate hearing care interventions if hearing care intervention is needed, as recent symptom may disappear or improve over time. Mm-hmm. The second aspect is tinnitus perceived location. So is it perceived in one ear, in both ears, or in the head? Okay. The third aspect is tinnitus spectral quality. So meaning is tinnitus high pitch or low pitch, right? It's important to highlight that tinnitus spectral quality often aligns with the hearing loss audiometric configurations. So high-pitched tinnitus tend to be more common or prevalent among patients with high-frequency hearing loss. So with tinnitus spectral quality and tinnitus perceived pitch help clinicians to make more precise and accurate diagnosis. So your fourth aspect would be specific characteristic of tinnitus. So is tinnitus in sync with patient's heartbeat? Are we dealing with a pulsatile tinnitus?
Right.
Is it synchronous or asynchronous, as we talked about in the first episode? Regardless, if a pulsatile tinnitus is suspected, patient should be referred back to their primary care physician for further evaluation. Fifth aspect is quality of life. So what are the emotional and functional health complications associated with the experience of tinnitus? Is tinnitus affecting patients' mood, concentration? Is it affecting their work performance? Is it affecting their sleep? And all of that. And the last aspect would be coping strategies, okay? So what is the patient doing to reduce the impact, the behavioral and emotional impact of tinnitus in their life? Are they relying on safety-seeking behaviors, right? So I often like to use the analogy of a mosquito bite. to talk about the counterproductive nature of safety-seeking behaviors. Repeatedly scratching the mosquito bite does not alleviate the itchiness. It just makes it worse.
I like that. It's a good way to kind of think about things.
Yeah.
Yeah, for sure. Okay, so maybe we can get into some of the assessment procedures now. You know, we've gone over the case history, but what assessment procedures in particular would you recommend for assessing tinnitus patients?
So, of course, the use of pure tone and speech audiometry procedures along with acoustic impedance measurement to identify any associated hearing loss. However, it's important to incorporate additional suprathreshold auditory measures, such as speech and noise testing or loudness discomfort level measurement, particularly for tinnitus patients who report hearing difficulty despite having normal pure tone thresholds on their audiograms. One thing I would also like to highlight is that many tinnitus patients attribute their hearing and communication difficulties to their tinnitus instead of their associated hearing loss for no fault of their own. Now, in 2019, I also collaborated on another health report with Statistics Canada, which examined the prevalence of undetected or unperceived hearing loss among Canadians. So we found that about 77% of Canadians between the ages of 49 and 79 were completely unaware of having a hearing loss, especially on the high frequency range. So it's important to highlight that many patients experiencing expressing tinnitus distress may actually be struggling with an untreated hearing loss on a high frequency range, right? As I mentioned in episode 1, subjective tinnitus is almost always experienced alongside some level of hearing loss. So I believe it's in 2015, Henry and colleagues introduced the Tinnitus and Hearing Survey to help clinicians distinguish between hearing-related problems and tinnitus-related issues. And I'd like to also mention that about 40% of patients with bothersome tinnitus also struggle with a decreased sound tolerance condition, such as a loudness hyperacusis. So once again, left unaddressed, undetected, untreated, hyperacusis can really also reduce the efficacy of hearing care interventions.
Yeah, and I guess I'm thinking through some of those tests like loudness measurements and acoustic reflexes and admittance. I guess there should be some caution taken because we don't want to be a trigger for someone or exacerbate their tinnitus.
It's so important to obtain informed consent for the procedure. The procedure needs to be explained, the risk and all of that, especially with hyperacusis patient. Even the obtention of acoustic reflexes threshold would be included.
Yeah, so it's kind of like consider those things, they add value, but proceed with caution kind of thing.
Absolutely, yeah.
Very good. Okay, maybe you can elaborate now a little bit more on Axis 2 and the clinical implications for that part of the assessment. Yeah,
the tinnitus evaluation, or Axis 2, involves using psychoacoustic measures such as the tinnitus pitch and loudness matching procedures and standardized self-assessment questionnaire such as the Tinnitus Functional Index or the Tinnitus Handicap Inventory. So these clinical tools help clinicians better understand the persistent tinnitus sensations in terms of pitch and loudness, but also the emotional and behavioral impact it carries onto patients. Now, when it comes to prescribing and recommending hearing aids for tinnitus relief, the tinnitus pitch and loudness matching procedures play a critical role. Now, there are some studies that indicate that hearing aids are most effective when their frequency response aligns with patient perceived pitch, perceived tinnitus pitch. So the recommended hearing aid should be equipped with a frequency response or a bandwidth in a fitting range capable of amplifying soft and gentle inputs in the tinnitus associated region in the audiogram.
So having gain for soft sounds and having a wide bandwidth offers some benefit. Really characteristics of a Widex hearing aid, really.
Right, right. It shows also that most likely patients with high-pitched tinnitus will greatly benefit with hearing aids equipped with an extended high-frequency band or range.
For sure. Okay, now I'm hoping you can review the tinnitus pitch matching procedure. Sometimes we get clinicians asking about that.
Yeah, that's what we call a two alternative forced action procedure. So, I know. So, two tones are presented to patient at 5 to 10 dB above their hearing thresholds, and patient is asked to identify the one that most closely matches their tinnitus. So this continues until a match is done.
Right.
Okay. So it's always good to do an octave confusion test after that, which is the phenomenon with further testing, where the perceived tinnitus pitch happens to be one octave above or below the initial tone that was matched with. Yeah.
Right, right. And I can put myself in the patient's shoes. I think in some ways it can be comforting to know that your clinician is assessing your tinnitus at that level, because it shows that you're being very attentive to their situation, and that can have benefit just in terms of setting the tone. Would you agree with that?
Yeah, the tinnitus pitch and loudness matching procedure is important while providing counseling to patients, particularly those tinnitus patients with normal pure tone thresholds.
Sure. Somehow
illustrating tinnitus on the audiogram, such as like drawing a solid dot below the hearing threshold that corresponds to the tinnitus, provide patients with a lot of validation and a reassurance that their tinnitus symptoms are real rather than imagined or psychosomatic.
Of course.
So yeah.
Of course.
Yeah.
Okay, and lastly, maybe you can take us through Axis 3, which is the well-being screening and some implications for using it clinically.
Yes. So as we discussed in episode 1, patients with bothersome tinnitus are more prone to anxiety and depression. Therefore, screening for emotional and behavioral disturbances is critical to prevent ineffective hearing care interventions, whether it is amplification or sound therapy. So clinicians often rely on user-friendly self-report measures such as the Hospital Anxiety and Depression Scale, or even just the Patient Health Questionnaire to screen for well-being. So these clinical tools enable clinicians to identify potential mental health conditions such as anxiety and depression, necessitating further assessment and management by a mental health care professional.
Right, right. Now, what would you say to a clinician that objects to doing this type of well-being screening because they don't have enough time and there's costs somehow associated with doing it?
Well, all of these self-report measures are accessible online for free. And they come with scoring instructions and procedures. Okay, I typically request patients to complete the detailed case history form along with the tinnitus functional index or tinnitus handicap inventory and the tinnitus hearing survey and the hospital and anxiety and depression scale prior to their visit to the clinic or while they're waiting for the appointment. So reviewing and scoring these forms takes about 5 minutes.
It's not a big, it doesn't require a lot of time.
No.
And they're free, so
yeah,
that's good. Now, what would you say to a clinician who has concerns maybe that doing a well-being screening isn't within their scope of practice?
Yeah, well, clinicians should be cautious about screening for emotional and behavioral disturbances and should definitely stay within their scope of practice. Now, it's important to remember that hearing care professionals are not permitted to diagnose any sort of mental health conditions or even suggest the potential presence of anxiety or depression. However, clinicians are permitted to conduct well-being screening to screen for emotional and behavioral issues and to communicate to patients that their screening suggests the potential presence of such disturbances that may require further help or assessment and management from a mental health care professional.
Absolutely, absolutely. Okay. Well, thanks again, Danny. It was great to talk about some of these things. And I think there's a lot more to talk about from a mental health perspective as it relates to tinnitus management.
Yeah.
And, some of the strategies or tools that clinicians can use when having to have those conversations with patients in the clinic.
Absolutely.
So we'll maybe get to that next episode. So, thank you everyone for joining us today, and we look forward to your attendance in the future at a future Widex podcast.